Welcome back to Rarely Typical, a podcast where I am talking about living with a chronic illness, finding hope, and living a life that is rarely typical. Today, we have an exciting guest. I started this podcast and did not want to sit here and talk just to myself. So I do feel like it would be beneficial for everybody listening to hear from people that are not me, hear from people in the field, and also hear from other patients. But today we have a great treat and we get to talk to my doctor from Colorado who diagnosed me and started me on treatment, and the one that I don't talk bad about, Dr. Hountras.
Hello,
Welcome.
everybody. Thanks so much for having me, Gerry. It's great to be here. And for everybody that I haven't had a chance to meet yet, my name is Peter Hountras, and I'm a pulmonary critical care doctor that lives in Colorado and have been a part of pulmonary vascular disease, specifically managing and treating patients with pulmonary hypertension for the last 7 years.
He was my diagnosing doctor in September of 2018, and we have come a long way since we were both in Colorado. He is no longer my actual doctor. We all know that I am now saying Dr. Moss, but Dr. H and Dr. M both collaborate, and that's what I talked about in my last episode was collaborating doctors. And today, him and I are collaborating, and we are going to talk a little bit about new drugs.
That's right. New drugs are trying to come out all the time. I mean, even just in the last 10 years, we've seen so many drugs going through clinical trials and quite a few that have been able to make it out into mainstream to be able to help treat our patients. I think one of the things that's not as well known for our patients is the extensive time that it takes for a drug to kind of go through the development process before it actually hits FDA approval and being out there in the market for our patients to be able to benefit from. And there are different levels or phases as far as what we call about for clinical trials. So the earlier phases, looking at the safety of the medication in the general public, moving on into the later phases of actually being able to prove that the drug does what we hope it does. So that way we can then get it out to market and be able to use it in the real world. And then usually during that time, there's actually even extensions of those trials and what we call phase 4 studies, where we try and gather as much information as we can as far as what's actually happening when we get this out into the market. And so many more patients outside of the study have the ability to get into that. And so today I felt like it would be a good opportunity for us to talk about several of the drugs that have even more recently come out to the market in the last 12 months or are currently going or undergoing clinical trials right now that some of your listeners might have the opportunity to take part in or have heard about.
There are a ton of new drugs that are always coming out on the market. We know that there are clinical trials that are always in progress. It is so exciting to be part of a clinical trial, and I love that I was able to be part of the clinical trial that I'm currently on. I know that a lot of the time, clinical trial can be a last resort for people. And I do want to encourage you that I don't think that it should be considered a last resort because sometimes doing it in the middle of your treatment can change your entire life, and it has changed mine. So, while we were talking about clinical trials, and I'm going to share my clinical trial experience at some point, I do want to talk about new drugs because I feel like that is a question that I get all the time is like, what is new? What's going on? What happens next for the treatment of pulmonary hypertension? I know a lot of people are sometimes disheartened by trials that no longer are working or trials that get canceled. But I know that there's a lot of trials out there and drugs that have come out that can be very beneficial. So today, Dr. H is going to tell us a little bit about some new drugs and things that we can look forward to.
So I figure first we can talk about Opsynvi. It's the newest pill form that came out about April of 2024. The drugs itself are actually not new. It's a combination pill, first time that we've had that in pulmonary hypertension, that combines both tadalafil, which we know is a phosphodiesterase inhibitor, as well as macitentan, which is an endothelin receptor antagonist. And instead of having to take two separate pills, they combine it into one pill, so you only have to take one pill once a day. And everybody might say, well, why was this necessary? I'm fine on both of my pills. But as you guys know, or have been in the pulmonary hypertension space for a while, pill burden can definitely be an issue. And the more your disease may or may not have progressed, as we talk about adding on other therapies, trying to simplify things actually can make a lot of benefit for patients. And so prior to the release date in April of last year, There were studies done that looked at the combination of both in the same pill had the same ability to improve patients' lives as far as pulmonary hypertension as taking the two pills separately. And they found that the compliance or the ability for patients to actually take it on a regular basis was improved. And so, with that, we now have the ability, instead of giving you two separate pills to take once a day, or for those that might have been on sildenafil, where you're taking that 3 times a day, to now take two medicines, one pill once a day.
It's a combination pill. That means that you take less pills a day. How do you feel about doctors who say they would rather start patients separately and then move to the combination pill?
Yeah, I think there's lots of ways to approach the utilization of this medicine. Anytime you're starting pulmonary arterial hypertension medicines, we almost always talk about you will have some type of side effects. These medicines, it's not like when you take your antibiotic that you get for a urinary tract infection or pneumonia, where you think that, okay, maybe you might have these side effects, or your cholesterol medicine that maybe you might get some muscle aches. Our approach is always saying that one of the ways that we know these medicines work is because they cause some side effects, and that over time, those should get better. And so there has been some argument back and forth as to, well, would you start them both on the same day in the same pill? Would you stagger the start, do one pill at a time, get them used to the medicines, and then switch over? I think any and all of that is fine. I think that the biggest thing is to kind of be upfront in the conversation, and that you and your doctor have the ability to have that open relationship and dialogue about what are the concerns. Maybe how sensitive are you to side effects that you've had from other medicines, or that you had exposure to some of these medicines before, that you've seen some of these as far as worse side effects, or you've got other underlying medical issues, maybe stomach issues or bowel issues, that having two medicines that both could cause GI upset, nausea, vomiting, and diarrhea may not be the best to start at the same time. I think there's definitely some negotiation there. In my limited and anecdotal experience, I have not had patients who have started this brand new have a whole lot of worse side effects than when I've staggered them and done them separately. But again, everybody's a little bit different. And so I think it's at least worth having that conversation with your doctor and say, what are the side effects that you think I'm going to have? What's your experience been as far as doing this in the same pill versus doing them separately? And then you guys having a shared decision-making plan of action as far as how to kind of tackle that.
I have one more question. So, when you are doing this combination pill, and I know that sometimes doctors change medications. So, like I went from sildenafil to tadalafil. What happens when you're taking a pill that is combined and a doctor wants to change the metasine? Like how do you know what the benefit, I guess, and the risk is of like changing one of the medicines when you're technically getting both of them at the same time? Does that question make sense?
Yeah, that question definitely makes sense. I think, again, it goes back to our understanding that tadalafil and sildenafil are kind of in the same family, or we call them class of medicines. And so they work on the same receptors. They cause the same type of vasodilatation through the same way. And so we think that there should be a shared effect across that class. And so as long as you're getting a medicine in that class, you should still get a similar benefit. And so going from sildenafil to tadalafil, you should hopefully get a similar benefit from the same thing that you were on from that drug to the other drug without a whole lot of difference. There will need to be, if you're on sildenafil or already, a little bit of a washout period before you potentially can start the tadalafil. And you don't want to double those up, because if you end up overlapping the amount of time that the sildenafil is in your body when you're taking the tadalafil, you could really cause worse side effects, especially low blood pressure. And that could be extremely dangerous. And so that part there needs to be a little bit of an understanding of, when am I stopping this medicine and when am I starting it? Similarly, if you're on ambrisentan or Letairis, for example, and now you're switching over to macitentan or Opsumit, meds in the same family, doing the same thing as far as endothelin receptor antagonists. They work a little bit different because they work on different receptors, generally have similar side effect profiles, maybe a little bit less leg swelling in the patients that take the Opsumit or the macitentan, but overall similar type of approach. So the hope is that if you go from two separate pills to that one combined pill, that you're really not going to see a whole lot of difference, both in efficacy or the pill's ability to do what we want it to do and help the pulmonary hypertension, but also the side effects.
No pressure, but the next drug that we are talking about is one that I would love to be on if I can get off pump. Let's have a conversation about it.
So the next drug we're going to talk about is Eutrepia. It's a drug made by Liquidia that is not yet out to market, but is hopefully going to be out, I think, later this year, potentially by this summer. The drug itself is actually not new. It's treprostinil, which is available both in IV, subcutaneous, inhaled, and oral forms. And so some of your listeners may already be on that. I know, Gerry, you have obviously a lot of experience with the subcutaneous and previously the IV form. So the drug itself is not new. We know how well the drug works. The difference in what Liquidia as a company is trying to do with Yutrepia is actually change the way that it's delivered through an inhaler mechanism. And so for anybody that's got a history of asthma or has family members with asthma or COPD, you guys are probably familiar with the dozen or so or more devices that deliver inhaled medicines like albuterol and other things all the time. If you take a look at each individual medicine itself, yes, sometimes the medicine is actually different. But the bigger thing is that the actual way that they deliver the medicine is the biggest difference between those devices. So similarly, Liquidia is coming to the market with a different way to deliver inhaled treprostinil. So United Therapeutics is the other one that makes these types of medicines in two different forms. There's the nebulized form with that really big special nebulizer that you can take around with you. More recently, they've got the dry powder inhaler, which fits on the size of a keychain that again, you can take around that is more similar to some of the inhalers that we have on the market for things like COPD or asthma. Similarly, Liquidia with Yutrepia wants to do a different version of a dry powdered inhaler. So they're going to similarly take the treprostinil medicine. They've come up with a way, and I don't fully know their machines and their algorithms and how they do it, but the way that they describe it is that the particles are more uniform in size and shape, and that their inhaler takes a lot less effort to be able to deliver the medicine over continuous flow. And theoretically, they feel like it will get better deployment into your lungs, which then will allow for better absorption into the lungs and better utilization as far as the medicine. And the biggest thing that they think that sets their device apart from other devices on the market is to try and help lower the burden of symptoms that patients get when taking the medicine through this route. And so obviously, all of you that have had exposure to prostacyclins, you know all about those side effects. We're not going to spend all that time talking today about the wonderful things that come with prostacyclins. But the biggest difference between other prostacyclins and the inhaled ones is the addition of the side effect of cough. And cough can be a very, very big issue that can keep patients from staying on the medicine long term, especially if they are on it because they've got some underlying interstitial lung disease, or maybe that's their primary diagnosis and they're more an interstitial lung disease patient that has pulmonary hypertension. And so giving somebody that may already have cough a drug that causes cough, even if we're trying to give them benefit, may not be the right thing for them.
Can you describe what the pump looks like? Have you seen it?
So it's a very small dry powdered inhaler. I think it's similar in size to the one that's on the market currently, but its mechanism is completely different. And not having an engineering background, I don't know that I can specifically tell you that the differences other than what they've talked about on their website and they've expressed in the public forum settings, as far as it's supposed to be an easier ability to be able to inhale the medicine, more of a continuous flow state. Particles are supposed to be more evenly sized and shaped, which will help with distribution into the lungs.
So it looks like a DPI.
So it
Okay.
is a DPI. It's a similar size, from what I understand, to the other DPIs that are on the market. It is not big and bulky. It's going to be easy to carry around and take with you on the go as you're living your active daily life. It is definitely, again, something that's a little bit more mobile than the traditional nebulizer, but it is going to be particles that are made in a different way and delivered in a different way than what we have out there right now with the current DPI that's on the market. The nice part about this is that there are more options for patients. And while there are several different types of devices, nebulizers, and now two different dry powdered inhalers, it adds to the opportunity that hopefully patients will be able to find one that works best for them. It's not going to be likely a one size fits all, but it's going to be allowing more people the opportunity to find an inhaler that works, that doesn't have a whole lot of side effects, that provides them benefit with the medication.
So they're not launching a new medication, they're launching a new pump.
Correct. New pump and a new way to formulate the medicine. I think both of those are what is unique about this company, because treprostinil has been on the market for quite a long period of time. And so they were able to take a drug that has already shown benefit and then be able just to manipulate how they're delivering it to do it in a different way that they think is going to provide a benefit for some patients.
I want to do an inhaled pump at some point. For all the listeners, we will have Moss on and we'll see what he says and put it on camera. And so he can't deny that he said anything. So if you're listening, Moss, just know that you're coming. Okay, let's talk about the next drug.
Yeah. So the next drug we're going to talk about is one that's actually currently in clinical trial right now. It's called seralutinib. It's a medicine that kind of works more on potential inflammatory processes that could happen within pulmonary arterial hypertension. And it's actually the idea for it came off of a different medicine that was looked at for pulmonary hypertension years ago. So there's an older medicine that was originally looked at for patients with different types of blood cancers. And some studies were done with that medicine in the realm of trying to treat pulmonary arterial hypertension. And they actually were starting to come positive. The problem was is that while they were doing and using this drug, they saw that patients were having significant side effects, including severe bleeding and very rarely sometimes bleeding in the head. And so because of those issues, that medicine was stopped and kind of put on the back burner in favor of all of the other medicines that are currently out right now that we are using every single day to be able to help treat pulmonary arterial hypertension. That said, though, the idea and the hope of being able to have something similar or to even find a different way to be able to give the drug that could be safer with less side effects, but still potentially beneficial has always kind of been in the background. And so the clinical trial that's going on right now is looking at, we'll say, a cousin of that original drug. Again, it's called seralutinib. It is inhaled, similar to what we had previously talked about with the treprostinil, but different drug in this situation, being utilized to try and help manipulate the underlying vascular bed in the lungs, decreasing the pressure and improving as far as pulmonary hypertension. This drug is still in clinical trials, finished a phase 2 study some time ago that showed improvement, especially in patients that were closer to a functional class 3 or were still not able to do barely more than their normal activities around their house, clean dishes, those types of things, not able to still be where they want to be from a goals perspective from their functional ability. And so with that, they then made a phase 3 study, which is currently enrolling at many sites across the country. You can find out more about what sites are available through clinicaltrials.gov. And essentially, it's trying to enroll patients in two different arms, one arm that gets the drug and one arm that gets a placebo or essentially like a safe sugar type substitute, and be able to combine to see what happens when you add on the seralutinib inhaled to the medicines that you're already taking. And is that going to help from a longer term perspective as far as your pulmonary arterial hypertension? I'm not sure where they are as far as enrollment, but I believe that their goal is over the next year or so to finish enrollment and then for us to be able to have an understanding as far as that data. And then if the study becomes positive, then the hope would be that the FDA would be able to approve that medicine into normal clinical practice for us to use with our patients.
Moss actually asked me at my last appointment if I would consider being also on this study. But we did talk about that he was not very impressed by the clinical trial results. Do you feel like it is as beneficial as they're making it sound?
Yeah, I think if you look at the phase 2 data, the most impressive results were in the patients that were more functional class 3, right? So it seemed to be less helpful in patients that were more functional class 2, so a little bit better as far as their functional status. But again, a phase 2 study is not the same as a phase 3 study. And we all have seen in our lifetime in medicine, two studies that looked really, really good, where the phase 3 study came back and was completely negative, and phase 2 studies that they realized that either they weren't asking the right question or weren't actually looking at the right group of patients. They reformatted their approach, did it right for the phase 3 study, and then showed benefit. So again, I think in all of these things, we have the benefit and the privilege of 25 having a big options of meds, and not every med is necessarily going to be beneficial for every single patient, right? And so there likely is going to be a really good subset of PAH patients that seralutinib might be better for, that, that might not be the best drug versus something else for that same patient, right? And so I think that's where we're going to be able to see opportunities, or hopefully we're going to be able to see in their studies as far as who really benefits best. And so as we think about these things going forward and having further conversations between doctor and patients as far as all the different options that we can try and help identify or help say, well, this was the subset of patients that had the most benefit from this drug versus this drug, and then have that conversation together to be able to find out what might be best going forward for treatment.
I said absolutely not. You cannot pay me to be on 2 clinical trials at the same time right now. I'm so ready to be done with this clinical trial because it has ruled my life for the last, like, 2 years. I just feel like the continuation of a clinical trial on top of the clinical trial that I'm doing right now is just me, like, chaining myself to Mayo. So I was like, "No, I don't think so." Especially because when I looked at the data that Moss sent to me, I felt like it was like a 60% success rate or something like that, and I don't feel like 60% is personally enough for me. It might be for some people that are farther along in their progression, but, like, I feel like where I'm at, it just didn't make sense for me. But I am excited about this drug and this clinical trial and to see what the next phase looks like. So I spoke with Gossamer, and I will drop a link in the show notes for their enrollment because they are looking for people to enroll right now. So if you are interested, I will drop a link in the bottom for this one. On our list of drugs that we are talking about today is the drug that everybody is talking about, all of the buzz, especially if you follow me on any of my social media channels. You know that I have been enrolled in the sotatercept clinical trial for the last like 3 years. I have been on drug for what, 2 years now, which is crazy. It has done so many beneficial things for me, but there also are a lot of risks that come with it. And it also means that my time is dedicated for the most part to being a lab rat.
Yeah, that's a great intro, Gerry. And I'm very thankful to you and so many other PAH patients across the country and across the world that have taken the opportunity to be a part of these clinical trials for us to have the information. And it was an amazing day for pulmonary arterial hypertension for us to be able to have the first brand new pathway for this disease as far as drugs to target in a very, very long time. And extremely excited to be able to have new opportunities for our patients. And as you said, it's been all over everywhere and for right reasons. Sotatercept, as hopefully all of you guys know, is the first drug that has come out to try and target what we think is the underlying genetic dysfunction in pulmonary arterial hypertension. And so we think that in patients not only that have heritable or familial disease, meaning you inherited it from some member of your family, but even with those with idiopathic or those that have done drug and toxin or connective tissue like scleroderma, all have some problem with what we call BMPR2, bone morphogenic protein receptor 2. You don't have to remember that. There's not going to be a test at the end of this, but that specifically is downregulated in patients with pulmonary arterial hypertension. And its job is to help balance the development of new blood vessels with the destruction of old blood vessels. And so when it's downregulated, the body shifts over into creating and or manipulating blood vessels. And that is what we think leads to some of the constriction, some of the hypertrophy or the formation around the blood vessels that then causes the constriction and increases the pressures in pulmonary arterial hypertension. So the thought was, if we are able to figure out a way to reverse that process and to rebalance it, then not only will we lower the pulmonary pressures in the lungs, but that we actually may be able to see for the first time ever some sort of reverse remodeling where those vessels start to potentially look more normal. And so that was the big hope with this drug coming out to market. And what we've seen, both from the studies, the phase 3 study that was published already, and we've got 2 or 3 other studies that will hopefully be coming out with some data in the next 12 to 24 months, that patients that are getting on this, that we're seeing improvements, just like Gerry's talked about for herself, as far as her pulmonary pressures, her right ventricle size, function, shape on echo, all of those things. And that is happening. And that's absolutely wonderful. But just like Gerry said, no drug, nothing you can even pull up from the ground comes without potential side effects or risks if you're going to put it in your body, and whether that's orally inhaled or injection form. And just like that, this drug too has some side effects that are experienced on a range of levels because the drug itself is a non-specific binder, meaning it's not just binding to one site in the body, potentially binding to multiple. With that, you could have some unintended consequences that could cause things both in the short term of being on the drugs, as well as potentially more long term. And with that, I think, Gerry, you talked about some of the things that you've experienced, right? So the nosebleeds, being a pretty real one that a lot of patients will experience. Changes in things like hemoglobin and platelets that also potentially could affect bleeding. Patients that have had GI bleeding before, maybe at more risk of GI bleeding. And what we think may be happening is that some of that might be from the shifting as far as the blood vessel formation and the way that this drug is interacting with pathways that are close by to the pathway with the BMPR2.
Yeah, the bleeding sucks. I mean, I think at the end of the day, I think out of all of the things that's most annoying is on Sunday, I was on my way to church with the kids and my nose started bleeding. And I thought that, like allergies and pollen are crazy right now. So I thought that my nose was running. And so when I wiped my nose, it was blood. And then the next thing I know, it was like gushing down my face. Like I caught it like this. And obviously I had white pants on naturally and I was, like, holding all of this
Of course.
blood in my hand while I was trying to drive. I had to, like, pull the car over, like, it was, like, a whole thing. And I have never had nosebleeds in my whole life until I started on this drug, and so the nosebleeds have been very dramatic, but it's weird too because up until the last injection, which was less than a week and a half ago, I didn't have nosebleeds for like 2 months. So I'm not super sure what the reasoning behind when the nosebleeds happen is. Maybe I'm just picking my nose a lot. I don't know. I don't have any idea what causes the nosebleeds because I do go periods of time where it stops. But the other side effect is that it has made me better. So I also feel like I've been getting overdosed on my other meds. And I feel like that is like a complication that everybody has been talking about because, the side effects of the drug are headaches and jaw pain and diarrhea and all that stuff. But I also feel like I am better. So I feel like I'm getting too much of the pump or I'm getting too much of my oral medicine, and then it makes me wonder, like, am I just overdosing on everything else when this medicine is working so well? Like, I don't know what the balance is there.
And third thing, and that's a question that we don't yet have an answer to, and why it's so important for you to continue on in the extension study and for there to be more real world data kind of obtained over the next several years so that we, as the physicians and the nurse practitioners and the PAs that are providing this care, have a better understanding from an objective standpoint of how do these meds really interact in the long term? What happens as somebody's heart continues to get better? How do we potentially think about backing off or transitioning if possible, from things like pumps to other medications? What does that look like? What's the timing of that? How quickly can we think about those things? I will say, and I want to say this up front, there's no guarantee that by getting on this medicine that your other medicines are going to go away or that you're all of a sudden going to be able to come off of your pump. And that is not something that we're seeing. Is it possible, like Gerry was saying, that maybe there's a synergistic type of an effect where now you're getting double the amounts of side effects because your heart is doing better? We need to think about coming down on dosing. Absolutely. And I think that's been seen for sure. But all of the other stuff, as far as how far do we come down? When can we think about going from something that's IV or subcute to oral or inhaled? How do we think about the roles of these other meds as far as what are they really doing together? Or can we even think about spacing the sotatercept medicine out over time? Do we really need to always do it every 3 weeks? Can we get to the point where we're doing it every 4 or 6 or 8 weeks? Or can we do breaks? Like, what happens if you were to decide to stop being on the sotatercept for a couple months? How permanent are some of these changes that they may still last for 6, 12, or however many months? And these are all questions that have been asked and posed, but nobody has answers to. And the only guidance that we have is the studies that have been done that say we need to give this medicine every 3 weeks. And so I think the cool thing about this is that while this is definitely helping a lot of patients in a new way, it's also opened up an opportunity for us to ask a lot more questions, right? When and at what point do we think about starting this med? At what point do we think about de-escalating other forms of care? At what point do we think about potentially having breaks and those types of things? And so I think you're going to see over the years to come a lot of interest, not only in probably fine tuning this medicine to find one that maybe has less side effects and is a little bit more specific, but also to be able to help us try and understand how can we incorporate this medicine and does it really have to be delivered in the same time schedule that it is now, or do we potentially get to a point where we're able to back
Yeah,
off?
Moss said to me that he thinks that it is or Berger said to me, one of them said to me that they think that it is more of like a rescue before you have to talk about transplant. Is like triple therapy and now you need something else and adding this and then maybe taking it away once you get better. And I think that's what they're considering that it could be potentially. But I mean, just like you said, it's all questions, right? And it's so interesting
Yeah.
because a lot of people want to say that this is a cure, and, like, I have had to dispel that and say, like, this is obviously not a cure, but, like, with the verbiage of vascular remodeling, everybody is like, "So if it's remodeling, does that mean that it's curing what is going on?" And I don't think that's what it means, but can you explain what that means just a little bit?
Yeah, I think it's how the drug is partially working. So it is changing and affecting some of the underlying changes that have happened with pulmonary arterial hypertension, but it's not doing it to the point that it's all gone and your pulmonary hypertension is cured as long as you stay on this medicine. I think we are still far way out from that, but this drug is actively working on a molecular level to kind of help change the structure versus just purely causing dilation like our older drugs are. So it's definitely working in a different way. It's definitely affecting things differently and in a way that we have not had before. Again, I think the question is when do we start this drug? Where do we place this drug? How long do we stay on this drug? Are there going to be more specific drugs that come down the line because this drug has come out to market that might be with less side effects, those types of things? I think all of those questions are still very valid and things that I think people are pursuing. So, for example, as you said with Dr. Berger and Dr. Moss, two studies that are going to be published in the next 12 to 24 months. One is looking at earlier starting in patients, necessarily starting it at the time you get diagnosed, but maybe within the first 12 months or so. I think there's some wonder in that situation. If you start it earlier, maybe you will maybe prevent somebody from having to go on parenteral IV sub-Q therapy. Don't know. That's a question that's out there. Then there's also the study that's going to come out, the Zenith study, who looked at it in patients exactly like you said. They're on triple therapy. They're potentially facing lung transplant. They may or may not be a candidate for transplant. They can't tolerate going up anymore on their prostacyclin medicine because of the side effects that they're getting. They're severely limited by their life. And so in that situation, they also utilize this drug. And we're going to find out about that study too, to see if there was benefit or not in that patient population. Because those patients were not included in the original study that got sotatercept its first FDA approval.
This has been riveting information, and I'm sure everybody is very thankful to hear it from a doctor and not hear it from me. Also, everybody speaks in a little more jargon than I do, so it is what it is. I understand you, but I also know that some people are like, "What did he just say?" So, I'm hoping that everybody will go back and listen, but also I will leave links in the show notes so that you can also do your own research because that is a big part of your own self-advocacy is to do your own research and to also bring questions to your doctor and not just expect that your doctor is always going to have things to tell you, like, you also need to be in conversation. So I will drop some stuff in the show notes so that you guys can do your own research. Thanks to Dr. H for hanging out with me today. I want to make sure that I reiterate how important I feel that clinical trials are. I started because somebody recommended me start on social media. And so if you're listening to this, if you're finding this years from now, just know that I still feel the same way. I feel like clinical trials should not be the end all be all. I think that they should not be a last resort. I think that there's something that we should try while we're navigating what our journeys look like. I think that it's been so life changing for me that I would hope that if you start a clinical trial, it would also be life changing for you. But pulmonary hypertension is sort of a snowflake disease where it does not look the same for every person. It does not look the same for everyone with a chronic illness. Most people have underlying conditions, comorbidities. So it is different. And so it might not be the same life changing experience that I had, but maybe a different medication can. And that's the excitement of what the future of medicine can look like. So, with that, I'm going to let H close us out.
Yeah, thank you, Gerry, again for having me. I think talking about new medicines and clinical trials is always important as part of the landscape of a patient story through pulmonary hypertension. And as you said, you should never think about clinical trials as a last resort, but an opportunity for you to be able to be a part of the changing landscape of pulmonary hypertension. The only way that we have all the drugs that we have now is because there were patients like you that decided that they were willing to put themselves in a part of the process to potentially allow us to be where we are now. And that same thing can happen in 5, 10, 15 years down the road. And it allows not only for changing a spot for hopefully you and everybody else that's a part of the trial, but more so even just the future of patients that are going to get diagnosed with pulmonary hypertension behind you. and allowing us for to be able to create a space where we have so many different choices, so many different options, and who knows, maybe even being able to find that drug or combination of drugs that might be able to lead to a cure. So please, please, please talk to your doctors if you're at all interested in those things. Look at the show notes that Gerry's going to post. Go to reputable places like PHA's website or clinicaltrials.gov. If for whatever reason your team that's taking care of you for pulmonary hypertension doesn't have options, please find maybe somebody that is close by or ask them if they're in association with other larger institutions that are doing clinical trials that you might be able to qualify for and be a part of. This is the way that we get to all partner together as a PH community to push medicine forward and to hopefully have more changing days and more amazing drugs that are going to come out and have FDA approvals for, and we're going to be able to celebrate and see all those things done in the future.
And with that, I am so thankful for you guys for being here. I'm so thankful that you listen and that you subscribe and that you are here every week. H is going to be a reoccurring guest. He will be hanging out with me for some other things. We are going to talk about my story and our testimonies together, which has never been recorded. So when you get to hear my story plus his story of my story, it is actually really cool. So I'm looking forward to all of the things that we will have in the future. But for now, thank you. And thanks for hanging out, guys.